Four Hearts Worldwide and Pacemaker Club are excited to bring you Cardiac Café, a conversation on heart health and everyday living. This series will explore important topics on cardiovascular devices and what it is like to live with them as a recipient. Join us in the Pacemaker Club video library for knowledge, support, and stories that connect our heart health community.
Hi, everyone, and thank you for joining us today for the Cardiac Café, conversations on heart health and everyday living, sponsored by the Pacemaker Club and Four Hearts Worldwide. Our topic today is pacemaker and ICD basics, understanding the devices that help your heart. Our speaker today is Dr. Thomas Crawford. He is a cardiac electrophysiologist with many years of experience and implanting devices that we're talking about today. He's the chairman of Four Hearts Worldwide since 2022, and he previously served on the board of directors and as vice president and medical director. He also is a clinical professor with the University of Michigan. So thank you for this presentation today, Dr. Crawford. And I am your host today. My name is Linda Marie. I'm a nurse for a very long time and a nurse educator, consultant, and health coach. I'm currently the director of community development for HealthWise and Happy.com and the clinical program development consultant for Equality Agency. And I am also a pacemaker recipient since 2023. So 2 years, and I'm on my second device. So I've had some experience with this. So we're going to get started today, and Dr. Crawford's going to start off with the objectives and talk to us about devices.
Thank you, Linda, very much. Yes, so what I thought we would do today is start by discussing just the way that the electrical system of the heart is made up and what can happen to the heart muscle and the implications that that may have on whether a patient needs a pacemaker or an ICD. An ICD is an abbreviation of implantable cardioverter-defibrillator. We will explain the differences between those devices. And then we will discuss key aspects of living with a device, how it affects your life and what you have to think about when you have one of those devices. And then we'll end with questions, and hopefully I'll be able to give you some answers for the questions that have been forwarded to us. So the purpose of the heart is to pump blood from the top chambers to the bottom chambers and to the rest of the body on the left side, and from the top chamber to the to the lower chamber on the right side of the body to the lungs. In order for that to occur, there has to be a conduction system that is like a highway that's able to send electrical signals down and activate all the muscle of the heart at the appropriate time. In most circumstances, the rhythm is determined by sinus node, or you can say sinoatrial node. It is in the right upper chamber, and it consists of cells that specialize in spontaneous depolarizations that cause changes in the cell membrane of those cells that is then propagated down the conduction system. So that's the sinus node is your intrinsic pacemaker, essentially. If you are sleeping and resting, the heart rate is slower. If you're frightened or if you have to run upstairs, the sinus node will be stimulated by the sympathetic nervous system to increase that rate to be able to let you have the exercise that you would like at that time. When the signals come from the sinus node, through a variety of ways, they get to the AV node. And AV node is important because it is the location of heart block. And so the AV node is like the only place that connects the top to the bottom part of the heart. And so if you have damage to the heart muscle at that level, you may need a pacemaker because you cannot conduct signals from the top to the bottom. Other people have sinus node dysfunction, which basically means their conduction system is fine, but it's the sinus node that's not acting properly. So there's basically two main indications for pacing. One is sinus node dysfunction, and the other is AV node dysfunction. This electrical impulse propagates down the bundle branches and fascicles, and then ultimately to what's known as Purkinje fibers that deliver the electricity to the specific cells that need to be activated and then contract in response to the activation. There are two main types of pacemakers. Pacemakers have been around since the late 1950s, or they became more widely used in the mid-60s. And they initially were implanted epicardially, which means outside of the heart. And they sometimes can still be implanted that way if a patient is having cardiac surgery. But because of all the technological improvements that have occurred, most pacemakers that are implanted today are what's known as transvenous pacemakers. So in the left upper corner, you have a photograph of a pacemaker that is a dual chamber pacemaker. It consists of an epoxy header, the thing on top, which is transparent, and then the titanium can, which is the bottom part, that isolates the battery and the electrical system from the body. And then you have a couple leads that are plugged into the ports in the header. And so one of those leads goes to the top chamber, the right atrium. The other lead goes to the bottom chamber, the right atrium. And so if you, for example, have heart block and have normal sinus node generation, then the second lead basically keeps up with the top chamber by appropriately pacing after an appropriate delay after seeing a signal up on top. As you can see on the left lower quadrant, pacemakers are quite small, and they generally sit on top of the pectoralis major muscle, which is the muscle that we have in the front of our chest. Most pacemakers are placed under the skin and the fat tissue on top of the muscle. Sometimes devices can be put under the muscle, especially if patients have very little tissue there or if they have discomfort that results from the pacemaker being placed. There's a novel method of pacing the heart, and that is with a leadless pacemaker. So leadless pacemakers avoid the necessity of having leads, and so they are directly attached to the part of the heart that they're supposed to stimulate. The pacemaker on the left-hand side among the leadless pacemakers is a micro pacemaker. It's a Medtronic product, and that's the only company that makes that type of pacemaker. And so this pacemaker is able to pace the ventricle after it's inserted in the ventricle, and it can try to track the atrium, the top chamber, by listening to the contraction of the top chamber. So that pacemaker cannot pace the top chamber. It only paces the bottom chamber, but it listens to the top chamber in order to synchronize the beats. Then to the right, you have two specimens of a atrial and ventricular pacemaker called Avir, which is an Abbott product, that allows the physician to implant the pacemaker in the atrium or the ventricle. And in both cases, they're leadless devices that will stimulate one of the chambers. The two devices can be implanted together, and there's a very innovative way in which they communicate with each other so that they can actually track each other's progress based on what the other chamber is doing. While the transvenous pacemakers are implanted by putting a needle in the subclavian vein or axillary vein, and then putting the leads through that access site, leadless pacemakers are placed from the groin. And so a vein called femoral vein is accessed, and one or two of those devices are placed through the leg. And so there's no incision in the same way that there's one for the traditional transvenous pacemakers. Now, I mentioned that pacemakers are used to provide pacing support, as the name indicates, which means that they prevent the patient from having too slow of a heart rate. Defibrillators are different in the sense that their purpose is to abort cardiac arrest. So the purpose of both devices is to really watch the rhythm and then respond depending on what the patient's heart is doing. And so that's a feature of both pacemakers and defibrillators. However, it is only defibrillators that can discharge a high voltage across the chest between the lead and what we call the can or the generator in order to abort a cardiac arrest. And so defibrillators are generally indicated in patients who have had a cardiac arrest or who are at elevated risk of a cardiac arrest. Defibrillators as pacemakers can be transvenous, which is the way that they've been in widespread use since early 1990s. A more recent innovation is placing the defibrillator on top of the sternal bone and outside of the chest wall under the skin in a totally subcutaneous ICD. This type of device avoids having to go into blood vessels. And so it avoids some of the complications that may be related to indwelling leads in blood vessels, such as narrowing of the blood vessels or clots forming on them, or the leads becoming non-functional because of all the movements of the lead during the cardiac cycle and the respiratory cycle. And so a response to issues that cause trouble for patients with transvenous leads was the totally subcutaneous defibrillator. The limitation of this defibrillator is that it cannot pace. The transvenous device can be programmed to pace if that is needed. So the transvenous ICD really has dual function, both pacing and defibrillation as needed, whereas totally subcutaneous ICD only provides defibrillation.
Dr. Crawford,
Finally,
is it also true with the extravascular ICD does not pace also? Or can
well, so the extravascular device is an attempt to combine the features of pacing and defibrillation. And so there's different kinds of pacing. The pacing that pacemakers have for slow heart rates is not possible through extravascular ICD, but it can pace for a short period of time, several beats at a time, to abort a rhythm called ventricular tachycardia. So the extravascular ICD could potentially convert a lethal rapid rhythm by pacing even more rapidly and abolishing the circuit. And it would do that before trying to discharge across the electrodes. So the extravascular ICD cannot pace all the time, but it can pace at the time of its detection of ventricular tachycardia.
Yeah, so it senses that rhythm, it'll kick in for a short period of time.
Correct. And so in order to be able to do that, that lead has to be put under the breastbone. So in a totally subcutaneous ICD, the lead is tunneled under the skin outside of the breastbone, whereas with extravascular ICD, the lead is tunneled under the breastbone, and it really sits on top of the heart, and that's how it's able to pace and capture and generate an evoked potential in the muscle. One other advantage of having the lead under the breastbone is that the amount of energy that is required for the discharge is less because it's inside the chest wall, not outside the chest wall or the rib cage. And that means that the generator can potentially last longer because it doesn't have to discharge to 80 joules. Instead, it just discharges to about 40 joules. So those are some of the key differences.
Yeah, it's for battery life, right? Very important for the battery life. And before we go into device implantation, do you mind telling us a little bit more about why somebody might need a pacemaker versus an ICD, or just the reasons they might have one or the other of these devices?
Right. So the pacemaker's primary role is to prevent slow heart rate. So it's like it has a timer. In both chambers have timers, and they depend on each other. And if a patient's heart rate either has a pause or if the patient's heart rate is inappropriately slow, the pacemaker stimulates the muscle and causes it to contract. So it actually fixes slow heart rate.
Okay, good to know.
The defibrillator is for a different kind of patient, a patient who is at risk of cardiac arrest. A lot of times when people die of cardiac issues, the lay public refers to the event as a heart attack, and oftentimes they are heart attacks. But there are also cardiac arrests which are not related to cardiac attack, and those are aborted. Those cardiac arrests can be aborted with an ICD.
When you say aborted, what does that mean to the person with the ICD? What happens?
So what happens is if this extremely rapid heart rate happens in the bottom chamber, and most programming assumes that heart rates above 200 are abnormal, and so the shock therapies usually are programmed at around 200 beats per minute, sometimes less, sometimes more, depending on the patient. But that is able to shock the patient if the heart rate is very fast, and then terminate this extremely rapid rhythm. So let's say that somebody's heart rate is 300 beats per minute. It's detected after several beats, and it's reconfirmed after a few more beats. And then usually the devices try to rapidly pace the heart for a few beats. And if that doesn't work, they deliver a charge, or they discharge, so they deliver a charge.
Like if somebody had a defibrillator and they are...
Right. So essentially the shock usually occurs within a few seconds, sometimes a bit longer. Most patients remember their shock and they think of it as very unpleasant. Farmers usually say it feels like a horse kicked you in the chest, and city slickers usually talk about a baseball bat being hit, your chest being hit with it. So it is very unpleasant when it happens, but it probably saved your life.
Yeah.
Now, sometimes
absolutely.
patients pass out before they are shocked. And so in those lucky patients, they don't necessarily know that they receive a shock. They may find themselves on the floor, or maybe even if it occurs at night, they may not know at all that they received a shock.
Okay. That's all very important to know. Thank you for explaining all that. All right. So device implantation and recovery.
All right. So let's first talk about the devices that are implanted in the chest. So those will be both the transvenous pacemakers and transvenous defibrillators. The surgical procedure is done in an OR-like environment. That's a combination of really an OR and a radiology suite. And so oftentimes these are referred to as cath labs or electrophysiology laboratories. And the chest is cleaned properly. Incision is made, a pocket is made between the muscle and the skin. And using a needle, a guide wire is advanced into that blood vessel, subclavian vein or axillary vein. And then over that wire, a sheath is advanced. And then you take the wire out, and basically what you have is a sheath that's in the blood vessel through which now you can feed either the pacemaker lead or a defibrillator lead. And so that procedure usually takes somewhere from 45 minutes to 2 hours, depending on the complexity of the anatomy and how many different things need to be done. Some patients have single chamber devices in which the lead is only in the atrium or only in the ventricle. For defibrillators, there has to be a ventricular lead. Sometimes there's a third lead. For patients with heart failure, there is a way of pacing the bottom part of the heart without allowing any delay between the left and the right side of the heart. And so those devices actually are called biventricular pacemakers or biventricular defibrillators, and they have one atrial and two ventricular leads in them. So depending on how many leads there are and what type of issues the implanting physician encounters during the procedure can be shorter or longer. Most of the time, patients undergoing those procedures are under conscious sedation, which means that the patient falls asleep but still has spontaneous breathing. Sometimes patients may be put under general anesthesia, which is placing somebody so deep that you actually have to breathe for them in order to allow for the oxygenated blood to circulate the body. So it is unusual to require a general anesthesia for these procedures unless they're combined with some other procedures that may require that, or if the patient's prior experience or certain comorbidities make aspiration more likely, meaning the gastric juice coming into the lungs. So there are some circumstances in which general anesthesia may be used. Traditionally, patients spent a night in the hospital. They were kept for what we call observation. So they would only spend one night in the hospital and go home the next day. It is possible, there are protocols that have been shown to be safe to actually discharge a patient the same day. And there are certain steps that need to be undertaken to make sure that it's safe to do it that day. And it really varies from hospital to hospital or from one surgical center to another, what the policy is for most of those patients. There's always a possibility of keeping one of the patients overnight or possibility of letting them home the same day. A lot of times it depends on the comorbidities that the patient has. Older individuals, those who are on blood thinners, those whose procedures were longer, or those who required more pain medicines may be kept overnight. Those who underwent relatively simple procedure and don't have any significant risk factors for a complication may be let home on the same day. It's really depends on physician discretion.
Yes. And Dr. Crawford, also, doctors like yourself have been doing these procedures for a long time. So it's very perfected, right? It's not, even though all surgery can have its dangers, this is something that is typical, not a unusual surgery, correct?
Correct. I mean, there are about 250,000 pacemaker implants in the United States every year.
Wow.
So essentially 250,000 people get a pacemaker every year in the United States. And in terms of defibrillators, about 100,000 defibrillators are placed every year in the United States. So yes, it is a routine procedure, but routine procedure does not mean that it is risk-free. And so you can reduce the risk of a complication to 1 or 2 or 3% in most circumstances, but you can never eliminate the risk altogether. In terms of the things that we would observe the patient for after pacemaker implantation or ICD implantation, we would want to make sure that when we advance the needle into the subclavian or axillary vein, that it did not cause a leak of air from the lungs, a condition which is called pneumothorax. So all patients who actually have new leads implanted in the upper part of the chest require a chest x-ray or two. There's also a way to make sure that there's no blood accumulating around the heart, which is a condition called tamponade. And it is one advantage of keeping somebody under observation for a few hours or longer. Some centers may choose to use ultrasound to make sure that this fluid is not there, depending on the risk profile of the patient and their protocols at that facility. When patients have devices placed through the groin, the restrictions are more related to bed rest. You can still go home the same day or the next day, but instead of focusing on the upper chest, here the focus is on the groin where the incision is made. It's a small incision, but it is incision nonetheless. And so in terms of what we would ask patients to do or not to do after an implantation, after an upper chest incision, we prefer that the incision is kept dry for at least a couple days and that it is not, you don't put any ointments on it or any other solutions, that it's basically allowed to heal on its own. That's really the most important recommendation. Some physicians, for patients with pacemakers implanted through and ICDs implanted through the upper chest, some physicians also impose a restriction in motion of that arm. There's really no study that shows that it's better. It's just kind of common sense. So sometimes the common sense advice is for the patient who, let's say, is a golfer and who had a transvenous lead placed, not to go swinging the next day. Now, how much time you need to fully grow the tissue in around the leads is probably about 2 months. So I would assume that most patients should be able to resume any activity they wish past the 2-month mark. And depending on the preferences of the physician, it may be shorter or maybe a bit longer. When patients are instrumented through the groin, you also want to keep that incision dry. And additionally, you want to prevent lifting heavy things. If any one of us picks up something heavy, there's an increase in intra-abdominal pressure, and there's a theoretical potential of rebleeding if somebody were to really strain very hard. And of course, that goes down, the risk of that goes down hour by hour after the recovery. So most of the time, if patients do heavy labor and they need to go back to work, I usually advise 1 or 2 weeks of employment for that. When patients have a desk job, they could really virtually go to work the next day if they chose to.
And my experience is different physicians have different requirements. So people should do what their physician asks them to do, because also procedures might not be exactly the same.
Correct. I mean, there are certain, basics that are occurring in all cases, but, let's say the length of time that you keep the incision dry may depend on whether you put glue on it on top of the suture or just the suture and steri strips. And so, yes, there are definitely procedure-specific things that only the doctor that implanted the device knows. And so at all times, that trumps anything that you hear anywhere else in terms of the advice that you get.
Absolutely. Thank you.
So in terms of what activities patients can have past I would say, if you exclude the very first 2 months after implantation, which we kind of covered in the last slide, essentially patients should be able to do everything that they've been doing before. There are some considerations in terms of electromagnetic interference where, people who, let's say, operate arc welding equipment or work in a factory that has very high electromagnetic fields, it may not be safe for them to continue with those jobs. And there are actually ways there are companies that will assess the strength of electromagnetic field in the workplace. And that is actually like a granted benefit for work, where the employer has to provide that type of confirmation. But other than those restrictions about electromagnetic interference with arc welding or being at a power plant, most patients are really able to do everything that they've been doing before. And that would include dancing, running, biking. You could even, do swimming or upper, boxing, whatever there's really no reason why you couldn't do those things if you really want to afterwards.
Yeah, that's important. A lot of people ask, and some people are worried about how they sleep. Can they sleep on that side where the pacemaker is?
Absolutely. So whether you sleep on that side depends really on your personal comfort or discomfort. Generally speaking, pacemakers are implanted on the left side. It's easier. It's just more of a straightforward curve where it's a C-shaped curve that you have when you access the heart from the left side. And so, the patient may have some soreness in that spot. We try to keep the device as medial as possible so that it doesn't run onto the shoulder. I would say at the very beginning, there may be some issues with tenderness, but in most patients after the first couple weeks, it really shouldn't matter whether they sleep on the left or the right side and whether the device is on that side or not. It's all about patient comfort, really.
Okay, so as long as they're comfortable, it's fine.
Yes. Now, in terms of sleep, many patients who are cardiac patients also have sleep apnea. And sleep apnea is a condition in which during sleep, the amount of oxygen that the body gets plummets. And so they're basically being starved for oxygen because the airway collapses or because the respiratory drive is not there. So there's this intervention called a CPAP machine that allows the person not to have their oxygen drop during sleep. And so since these are common comorbidities, I thought it would be reasonable to include it here. If your doctor thinks that you should have a sleep study, there are really significant benefits to treating sleep apnea if you have that disorder.
Yeah.
And there are really benefits to sleeping, 7 to 8 hours a night and getting a good night's rest. When it comes to travel, what I would say is that, outside of the very immediate period of time when you just had the surgery, you really ought to be able to travel anywhere. As I mentioned earlier, there's lots of people getting these devices every year. So these devices are ferromagnetic. So if a person goes through a metal detector, it will beep. Patients are usually given a card just to show to the TSA personnel that they have a device and that they need to be screened in a different way. But I'm sure if you forget a card, you'll be fine as well, because there's just so many people that travel and there's no way that they all remember to bring their card with them.
Yeah, my experience is, and I just traveled earlier this week, is that they never ask for the card. I just tell them, because they have two different scanners at most airports, even the small ones now. And the one, even though mine is Medtronic, says it's okay, I still go through the other. I just tell them I have the pacemaker. It's one where you put your arms up in the air, and they scan you. And after, if they're uncertain, they'll just pat you down, and you just don't want them to wave that wand over your pacemaker. But otherwise, and if I have gone to other countries since I've had a pacemaker, and I don't go through their scanners because they're the old ones, and I'm not sure how safe they are or not. So I just tell them, and they usually just walk me around the scanner. So I haven't had any real problems.
In any case, even if you, let's say, were forced to walk through the scanner, there shouldn't be any problem with walking through the scanner. The potential theoretical problem would be you staying inside the scanner, like, not moving forward, but actually stopping. And then, your device being exposed to the electromagnetic field for a sustained period of time.
Yeah.
But just walking through the scanner should really be fine as well.
Well, that's good to know, because also sometimes the lines stop. So you probably don't want to stand right up there close to the scanner for a long period of time.
That is correct.
Yeah. Walk through fast or stand back.
That's correct. Now, in terms of magnets, so magnets and devices interact. Pacemaker behavior changes when a magnet is placed on it. ICD behavior changes when a magnet is placed on it. And, the strongest electromagnetic field that you could imagine is in a MRI scanner. And for many years, having a pacemaker or defibrillator was really a contraindication to undergoing MRI. What could happen is that the lead could actually start conducting electricity and heat the tissue. And so there were concerns about the survival of the device itself after scanning and whether there would be any associated damage to the tissues in which the lead is embedded. In at least 10 or 15 years now, all companies have rolled out products that actually are called MR conditional. So they are tentatively okayed to be used in an MRI scanner. Patients who are dependent or who have a defibrillator need the device to be reprogrammed to a different mode, not really turned off, but reprogrammed to a different mode. And so when MRIs are scheduled, you will be asked whether you have a device, and Usually the clinic that follows the pacemaker or ICD will be the one that will provide information to the MRI folks about what type of device it is and how it should be properly handled.
Yes, I actually recently had an MRI, very recently, and that's what happened. The Medtronic, they used the Medtronic rep. So the Medtronic rep came, the cardiologist who was going to read the MRI was the one that gave the instructions for how they wanted the pacemaker set. They did it, and when I got out, the Medtronic rep returned my settings back to what they were before the procedure. All went just fine. All right, anything else on safety of devices?
If know when to call your doctor, what I would say is if the pacemaker is implanted and then, in the subsequent days and weeks, maybe up to 3 or 4 months, if you notice that it is getting red or swollen or it hurts, the pain should certainly not increase. When you leave the hospital, it should either stay the same or get better day by day. If you experience more pain or increasing pain, or if you see any type of drainage from the incision, that is definitely a reason to contact your physician to let them know about this. It could be an infection, or it could be an allergic reaction to the soap that was used to prep the chest. I wouldn't jump into any conclusions, but I would just say it's something that you want to pay attention to. And of course, if you have a fever, that really raises a red flag that there may be an infection going on there. In terms of defibrillators, since the devices can shock patients, oftentimes the question is, what do I do when I get a shock? And generally speaking, the answer is that if you receive a shock and you feel well and you're not short of breath, you're not having chest pain, it's okay to just call your doctor the next business day. Having said that, I think the first shock is really very, profound experience, and nobody will ever blame a patient for calling 911 and going to the hospital because they received a shock. That's entirely permissible.
It's scary.
It's scary, and of course, other than healthcare utilization and you being in the emergency room for many hours, there's really no major downside to it. But if you get 2 shocks on the same day or within a few days, that really is very abnormal, because that either means that the device is misreading something, like getting electromagnetic interference, or is getting noise from the lead being broken, or indeed there's something really bad happening to the heart, and so you really need to seek medical attention. I should also mention that all devices that are currently implanted in the United States have home monitoring. And I want to touch on that. So maybe until about 20 or 25 years ago, the only way that you could really talk to the device is by coming to clinic and having a wand placed on top of the device. And then the nurse or the doctor could get the information out of it. In terms of just battery monitoring, there used to be transtelephonic magnets. And so basically patients would put a magnet on the device, and then the device would pace at a certain rate. And that rate would correlate with whether the device has good battery or is getting low battery. That really was supplanted in around 2005 or so. And now all companies essentially provide the service where the pacemakers can be remotely monitored. If you have a transmitter either on your phone, or you can plug it into the wall in your bedroom. If there's some event that occurs, either the device discharges and you happen not to know about it, or if something is happening to your heart rhythm, if there's more and more of something that is undesirable, a notification is sent to the clinic that monitors this device remotely. Again, it's not done in real time, so you can't really expect that somebody is going to respond to it immediately. But within the next business day, these alerts are classified as, red alerts, yellow alerts. And so depending on the severity of it, anytime that somebody gets a shock, we will call them the next day. And so I strongly encourage patients to subscribe to this home monitoring service, as opposed to just rely on coming to clinic every 3 or 6 months. Because if you come to clinic and you get interrogated, if something happens 2 days after you left the clinic, you will not know about it until the next time you show up. But with home monitoring, you can know it the following day, when the transmissions usually occur around 2:00 in the morning. So it's usually the very next day that folks find out about it.
Is it when you say interrogation, so I've had this done, so it sounds bad, but it's really just little box they put over your device to read it, excuse me. But on the home monitoring, because I have the app on my phone, which I'm sure a lot of people do now. But is this true also for events like VTAC or other type of events people might have? Would that also be a notification sent to the doctor's office?
So that depends on a few factors. So the reports that are sent for pacemakers and ICDs do vary quite a bit. Usually you get more information from ICDs. And clinics can actually program the types of alerts that they want to know about. So for example, first onset of atrial fibrillation is a big deal because that's a new diagnosis. You want to be appraised of that. But then there are patients who may have had 200 episodes of atrial fibrillation. And so you don't want to be alerted each time. Basically, the clinics would come to a screeching halt if they were to handle all of the data.
Every time.
So there is some adjustment that is made by the clinics in terms of who needs what type of alert. And so I would say it's difficult to make a general rule about how that system would work without knowing what the device is, which company's device it is, and what those alerts are set at.
Sounds like it's good for people to ask their doctor in their clinics what exactly are the alerts they're going to know. So that, because it'll be mostly individualized to that patient. And the device clinic, if the doctor has one that this person's going to, would know. And if they don't have a device clinic, then the doctor and nurse or medical assistant or whoever they use is going to help them to understand how to get their questions answered and how to understand how their device is working. So it goes back to for patients, for people, for all of us who have pacemakers and ICDs, to ask a lot of questions, prepare them in advance, because we all forget, even myself, having trained patients for many, many years, I still forget myself. So I make a list of questions to take with me, preparing and making sure to ask the questions when you're there so you feel like you have more control over your situation. It's really helpful.
Yes, absolutely. I agree with that. One other thing I can mention, since we're talking about things to know about devices, is in general, you want to avoid electromagnetic interference. And there are a lot of questions about microwaves, and it really isn't a problem. All the household items are perfectly safe because the strength of that field is low enough. The one exception that we usually make to this rule is we ask patients, especially men who have breast pockets, we ask them not to put their cell phone on top of the chest, because it's then just a couple inches or less from the device. Usually what's recommended is keeping it at 6 inches or more from the device. And again, depending on the condition that you have, it may be a big deal or it may not be a big deal. If it were really a frequent big deal, we would be talking about it all the time. So, but I think just a proper, reasonable approach is not to place any type of transmitter on top of the other device.
Yeah.
And as a matter of fact, if you double the distance, the strength of the field will go down by a fourth. And so just stepping away from something that may potentially cause interference is very valuable.
And my understanding is that if you do accidentally get too close, well, I'll just let you, if you do say you get too close, interferes with your device, what do you do? Say your device, because I had that happen to me one time, and it's a little odd feeling, but my device reset eventually. But I'm definitely not the expert on this, and you are, so I'd love to hear.
All right, so I guess what I would say is if your device comes into contact with strong electromagnetic field, that will persist for a certain period of time. The pacemaker will switch to a mode in which it's not seeing your rhythm, it just paces, which is essentially what happens when people get an MRI scanner and are pacemaker dependent. You just basically, the device is not watching for underlying rhythm, it's just pacing. Defibrillators, on the other hand, could go off in a strong electromagnetic field that's sustained. And that's why we wouldn't somebody to do arc welding with an ICD, because it would basically might be interpreted as a life-threatening rhythm for which the patient would get the shock.
Very important to know. Yeah, thank you for explaining. And also
Sure.
Thank you for that cell phone tip, because my granddaughter is in her 20s and I see her put her phone in her bra on the top all the time. So if a young adult has a pacemaker, don't do that. I know it's common practice. So yeah, thank you for that.
Sure.
Okay, next we have some questions that we're going to answer for you. So stay tuned.